All right, let's dive right in. In the next few minutes, we're doing a rapid-fire review of the absolute must-know facts for your anesthesia and ICU exams. We're skipping all the fluff and getting straight to the core concepts that are going to make a real difference on test day. So here's the game plan. We're going to blitz through 5 key areas. We'll start with critical care neurology, then jump to respiratory emergencies, sepsis, renal intox, and wrap up with those high-stakes anesthetic complications you just can't afford to get wrong. Let's do this. First up, critical care neurology. These are the kinds of diagnoses where missing one tiny detail in a question can completely change the answer, so you've got to be sharp. Let's kick things off with Guillain-Barré Syndrome, or GBS. You know the classic picture they love to paint in exams, that symmetrical ascending paralysis? It starts in the feet and literally works its way up the body. It's a nasty autoimmune attack on your peripheral nerves, and yeah, it's a huge favorite for examiners. Okay, from our perspective, this is where it gets really critical. Examiners just love this question. So listen up. What is the one drug that is absolutely 100% forbidden in a patient with GBS? And the answer is Suxamethonium. And listen, this isn't a be careful situation or a relative contraindication. It is absolute. There is never a scenario with GBS where Suxamethonium is the right choice, period. So why is it such a big deal? Well, here's the physiology you need to know. Those denervated muscles, they get desperate. They start sprouting extra acetylcholine receptors all over the place. So when you give Suxamethonium, it hits all of them at once, and they all fly open, releasing a tidal wave of potassium into the blood. It's massive and potentially fatal. Here's another key number you have to burn into your brain for GBS. As that paralysis creeps up towards the diaphragm, you're worried about respiratory failure. So you're watching their vital capacity like a hawk. The second it drops below 15 milliliters per kilogram, that's it. That's your trigger. That's your definitive sign to intubate and protect that airway. All right, quick pivot to another neuroemergency, stroke. If you're thinking about giving a clot buster like Alteplase, this blood pressure is your hard stop. You absolutely must get the BP under 185/110 before you even think about thrombolysis. If you don't, you risk a catastrophic brain bleed. Okay, let's keep the momentum going. We're moving on to Section 2, respiratory emergencies. We're going to focus on how to ventilate ARDS patients and some critical management points for asthma and VAP. For acute respiratory distress syndrome, or ARDS, the exams want to know what actually saves lives. You can forget about all the fancy treatments you read about. For your test, there are only 2 things with a proven mortality benefit. Number 1, low tidal volume ventilation, that's 6 mils per kilo of ideal body weight. And number 2, putting the patient in the prone position if they're severely hypoxic. That's it. Now, what about Ventilator-Associated Pneumonia, or VAP? To diagnose it, you'll use the Clinical Pulmonary Infection Score, the CPIS. You should be familiar with these 6 components: temp, white blood cell count, secretions, oxygenation, what the chest x-ray looks like, and microbiology. If that score adds up to more than 6, that's your green light to start antibiotics. Okay, here's a nightmare scenario. Your intubated asthmatic patient suddenly goes into cardiac arrest. What is the very first thing you do? Before you even think about compressions or drugs, you pop the ventilator circuit right off the tube. This instantly lets all that trapped air out, which is probably what caused the arrest in the first place. It can be immediately life-saving. All right, next up, sepsis and shock. Being able to look at a set of hemodynamic numbers and instantly know what kind of shock you're dealing with, that's a core skill, and you can bet it'll be on your exam. You know, this slide really simplifies things down to a great analogy. Is it a pump problem or is it a pipes problem? In cardiogenic shock, the pump, well, it's busted. So your cardiac index is low and the body tries to compensate by clamping down on all the pipes, giving you a high SVR. But in septic shock, it's a pipes problem. The pipes are wide open, so your SVR is in the tank, and the heart desperately tries to compensate by pumping like crazy, giving you a high cardiac index. Pump versus pipes. Keep it that simple. This right here is pure pattern recognition. If you get a question describing an IV drug user who has a fever and a brand new heart murmur, your brain should immediately scream endocarditis. And the answer they're almost always looking for is Staphylococcus aureus hitting the tricuspid valve. It's a classic. Now, for our 4th section, we're diving into some high-yield renal and toxicology topics. We'll hit acute kidney injury, a couple of key electrolyte issues, and some classic overdose scenarios. For acute kidney injury, you need to know your rifle criteria.
Now, if you're trying to prioritize, really focus on the I and F stages. Injury means the creatinine has doubled or the urine output has been low for 12 hours. Failure means the creatinine has tripled or urine output is even lower for a full 24 hours. They love to test those specific cutoffs.
Okay, re-feeding syndrome. You take a severely malnourished patient and start feeding them, you have to be worried about this. The absolute hallmark sign to watch for is a massive drop in phosphate, profound hypophosphatemia. And what's the most crucial management step? You must always give thiamine before starting any nutrition. That prevents a devastating neurological condition called Wernicke's encephalopathy. Thiamine first, always. And for our final section, we're covering the big ones, the high-stakes anesthetic complications. Look, these are rare, but when they pop up, you have to know what to do instantly, without even thinking. Let's start with a really fundamental question. You're in the operating room, and your patient suddenly has a cardiovascular collapse out of nowhere. What class of drugs is the #1 suspect for causing anaphylaxis? The answer, and it's not even close, is neuromuscular blocking agents. Just look at this chart. They account for nearly 2/3 of all cases of anaphylaxis under anesthesia. Sure, antibiotics and latex are on the list, but muscle relaxants are #1 with a bullet. Next up, malignant hyperthermia. And here is the single most important point I can give you. The earliest sign of MH is not the fever. The fever is a late sign. The very first thing you'll see is a sudden, sharp, unexplained spike in the end tidal CO2 that just won't come down no matter what you do with the ventilator. That's your alarm bell. And when that alarm bell goes off, you act. And you have to know this dose cold. In a crisis, there is no time to be looking things up. The initial STAT dose of dantrolene for malignant hyperthermia is 2.5 milligrams per kilogram. It has to be instant recall. So we've covered a ton of critical ground here. From the absolute do not pass go contraindication of suxamethonium in GBS to the life-saving must-know dose of dantrolene for MH. Remember, these aren't just random facts for an exam. These are the points that can literally change the outcome for a patient and, yeah, for your score. Master these and you're building a seriously powerful foundation. You've got this. Good luck.